personalized information about how they could save money by switching medicines and by having the opportunity to actually save because they were in benefits that enabled them to capture those savings themselves. They weren't savings that went somewhere else in the system. They went right back to patients. So there are some very important steps as well in implementing this kind of choice-based system. I need to pay a lot of attention to making sure that people who are at higher risk have access to adequate coverage, and we try to do that through steps like risk adjustment and other types of government oversight. You need to pay a lot of attention to making sure good information gets out, and there certainly is more that can be done to help people be informed consumers about their health care and help make this easier for them. But patients, consumers, are an extremely powerful force in getting the quantities right and finding better ways to help people meet their medical needs, their increasingly personalized medical needs, at a much lower cost. So all of this is to come back to this question of where I started, on getting affordable coverage for all. We need to build on steps like the ones I've just talked about to get more value, to measure quality and cost, to promote payment reforms and benefit reforms and other policies that support better healthcare quality and lower overall costs. And this can fit into the debates that we're having about coverage as well. They shouldn't be separate. They should be combined. This past year, there was a big battle over children's health insurance in Washington, right? You all followed the S-chip debate, and for most people who were following this, where that ended up didn't give people a lot of optimism that we're on a path towards broad consensus about health insurance coverage reform. But I think that was in part a reflection of how the debate was cast in Congress this past year. There were two alternatives presented. One was basically an expansion of the kinds of programs, the Medicaid and S-chip programs, that have worked very well for families and children with incomes under 200% of poverty. The other was basically not expanding those programs at all. Now, I want to contrast that with what's happening in state capital after state capital around the country, where Democrats and Republicans have gotten together, if not to enact coverage reforms, at least to take steps towards doing so. Massachusetts did it. California came close. Other states that have not gotten as much press because they weren't going to universal health insurance coverage, but were still doing significant coverage expansions over the last couple of years, like Arkansas and Montana and many others, did this as well. What they did was something in between those two alternatives that I just outlined. They didn't just say that the government government programs are only for people with incomes of under 200% of poverty, only for the poor and nobody else. They said that, look, at higher income levels, people need some help with affording health insurance today. Maybe they don't need 90% or 95% of their health care costs paid, like is the case for people with incomes under 200% of poverty, but they need some real help. 40%, 50% subsidies up to 300% of poverty or so. That's what happened in Massachusetts. That's how they got a compromise there. People have a choice of health plans, but they get help. They get help on a sliding scale. Employers contribute something. Individuals